Welcome to SMP's webinar today, focusing on the new reality facing anesthesia challenges in ASCs. My name is Traci Albers. I'm the CEO of Surgical Management Professionals, and today I'll be talking to you about facing anesthesia challenges and what you can do about it in your own ASC. Specifically, today we'll be looking at what are the challenges facing our anesthesia providers, making sure you understand the business models that are in play or should be considered, as well as understanding what that has as an impact to your ASC. And lastly, but most importantly, talking about strategies that will allow you to more effectively partner with your anesthesia group. If we look at what challenges are facing anesthesia providers, some are the same as they were 10 to 15 years ago, but we have seen a precipitous change in the last 5 to 7 years with what our partners are facing. It relates to the demand and supply imbalance, as well as the shortages, in addition to reimbursement reductions. As it relates to demand and supply, we are seeing a greater shift, as most of you are aware, from the inpatient to outpatient environment. And in many cases, with that shift, we're increasing the number of operating rooms, but not increasing volumes all the time. Therefore, we have the same number of anesthesia providers to be covering more operating rooms. In addition, there are non OR anesthesia sites that are prevalent, whether it's dental offices, plastic surgery offices, so more sites of care where anesthesia is being required and they're being stretched. We're also seeing providers under the age of 40 looking for different lifestyles, more of a work life balance, not willing to work the hours as some of the older generation of anesthesia providers have been working. So, all of those creates this demand and supply imbalance. Compounded to that is provider shortages. The Association of American Medical College predicts there will be a shortage of upwards of 13,000 anesthesiologists by 2033. Nearly 30% of those anesthesiologists are projected to leave practice. So, again, we're seeing providers leaving the market. They're not generating enough going through school, whether it's anesthesiologists or CRNAs. In addition, and since the pandemic, we have seen accelerated retirements, and many workers have opted to move to more of a locum tenens position. They don't want that part time or full time work. With a shortage comes increasing costs. And so, in many markets across the country, we're also seeing increasing costs for providers. Salaries are going up, therefore, those costs are needing to be passed on somewhere. Namely, they're being passed through to healthcare providers. And I think another confounding factor that's contributing to the provider shortage is just burnout. Again, since COVID, it's been very challenging to work in healthcare, as we're all aware. And so physicians and CRNAs are opting, as I said, to retire early and get out of healthcare in some cases entirely. With all of those, you would expect reimbursement to be going up to help offset some of these challenges, but that has not been the case. Reimbursement has continued to decline for anesthesia. The anesthesia fee schedule for an average unit has decreased from $22.27 per unit in 2019 to $20.44 in 2024. So while costs are going up, demand is at its greatest ever. We're seeing a reimbursement being driven down, which ultimately results in the challenges that all of us are facing today. So, how does that impact your ASC? As you'd expect, is impacting our surgical schedules. When you have a shortage of anesthesiologists and CRNAs, we are finding it challenging to staff all of our operating rooms, procedure rooms, again, in office clinics. Since COVID, we've also seen a shift in the culture and work environment in healthcare where we see our nurses, our techs, and others don't have as high degree of satisfaction working in healthcare. Anesthesia is no different. So there's also dissatisfaction in their specialty and their job, which is contributing and impacting our ASC operations. And then lastly, and probably the most significant impact all of us are seeing is the impact to the ASC financials. 20 years ago, we would have never heard of a subsidy being paid to anesthesia to help support them and cover our ASC. Over the last 5 to 7 years, we have seen more and more surgery centers having to help subsidize or help offset some of the losses anesthesias are incurring by providing services at your ASC. So, how do we approach this from an ASC perspective? What do we need to do as ASC leaders? We can no longer sit on the sidelines and expect anesthesia to manage their business model and not fully understand what they're going through. We have to fully engage, educate ourselves, understand what the anesthesia model looks like, so then we're in a better position to more effectively partner with them, whether that's through employment or contract services. These next few slides are going to walk you through things you should be knowing, what you should be talking about at your ASC and better understanding. Everything from the anesthesia costs. What are their costs to run their business? What are the care model options that might need to be explored? And then how is a reimbursement being affected? If we first look at the costs that anesthesia is incurring, it's very similar to running your ASC. There's overhead administrative costs that they have to factor in. They have a billing office that has to get claims out the door. And so, again, if you are paying subsidies to anesthesia, they will have a percentage of that that's contributing for their billing rates. They have their malpractice insurance. They have the same recruitment costs, and I would argue greater recruitment costs than you have in your surgery center trying to recruit and retain anesthesiologists and CRNAs. And then again, their ever increasing salary and benefit costs. You, as an administrator, director of nursing, or as a board member for your ASC, truly need to understand these costs. There are benchmarks out there to help you assess those if you're assessing a contract with anesthesia, but these are legitimate costs that need to be considered and are required for anesthesia to run their business. We also take a look at SMP when we're working with anesthesia providers, again, whether it's an employed model or through a contract, making sure we're educated with their compensation models. We like to approach things from a macro perspective to start with, taking a look across the nation. You can get this information off the internet. What are you seeing for salary ranges? This particular slide comes from Sullivan Cotter and Associates, and they did a survey of physician compensation from 2019 to 2023. And so it takes a look at the gradual increase in anesthesiology. It grew at about 4%. CRNAs, as you can see on the bottom of that slide, grew at a rate of about 5%. Since 2023, I would argue that we've seen another increase pending your market. So this gets you in the ballpark at a high level, kind of where you should be looking. But then we highly recommend you drill down into the local market level. This slide shows you just some average data from ZipRecruiter, Salary.com, based on certain markets. So you can see what they're putting out there. But the best resource you can find is actually speaking to an anesthesia provider in your market on what they're actually seeing. We're talking with anesthesia providers that are not only having to employ providers, but they're also having 1099 or contract providers. Those come at a different cost. In some markets, we're seeing that locums or 1099 provider costs at $250 to $275 per hour, or maybe you're employed CRNA, you could get at 175 to 200. It is critical that you look at your local market and make sure you fully understand what those costs are. Not only to appreciate the challenges anesthesia is going through, but if you are having to pay a subsidy at your ASC, you need to validate that what you're paying is fair and reasonable. So it's incumbent upon you to understand what those costs are. Another key component that I think many people have taken for granted is how anesthesia care is delivered. There's different models for how anesthesia care is delivered. We have seen across the country it is very market specific, very market driven. We see in some markets, anesthesiologists are still personally performing, meaning they are sitting in the seat and delivering the anesthetic at that facility. That is probably fewer facilities. The majority we're seeing are a physician CRNA model where you have four CRNAs to one physician, which is a medically directed model. If a physician is overseeing more than four CRNAs, it's moving to a medically supervised model. Different reimbursement, different requirements from a compliance standpoint as well. We're also starting to see more of a shift to CRNA personal performance with no physician oversight If you're in a state where there is an opt-out, meaning CRNAs can opt out and work on their own. And then the last model we see less frequently is an anesthesia care team where you have the physician, CRNA, as well as anesthesia assistants. We work closely at our facilities with the surgeons, the proceduralists, and anesthesia to talk about what the model is the best clinically. There are very divergent viewpoints, if depending on where you live and who you work with, on what they deem as an appropriate model. So that is first and foremost our consideration is making sure, clinically speaking, and from a buy-in standpoint with your surgeons and proceduralists, they're fully supportive of whatever model you have and which you will move to. We have several markets in the last 2 years that have moved from a physician CRNA medically directed model to a CRNA personal performance, primarily driven due to cost. That change doesn't come easy. It takes a lot of education. It takes a lot of buy-in. And again, it's based on your market and what's most appropriate. So this requires a lot of conversation, but there is a high level of difference in cost, which I'll show you here in a moment. This slide breaks down for you those different care models and the codes that are used for billing. You'll see MD Personal Performance as a AA code, but it also breaks down then how that payment gets split, which is a key consideration as well with your anesthesia providers. So obviously your MD Personal Performance, the physician is getting the 100% of the payment from the payer. When it's a medically directed model, most often that payment is split 50% to the physician, 50% CRNA. Medical supervision is a little bit more complex and takes into account some of the base and time units. And then lastly, if it's a CRNA only, they're getting 100% of that reimbursement. This slide just talks to you about the different education levels and the different types of anesthesia providers, whether it's an anesthesiology assistant, whether it's a CRNA, as well as a physician anesthesiologist. In addition, it talks to you about 7 key elements that must be in place if you have a medically directed model with a physician overseeing 4 CRNAs or 4 concurrent cases, and the compliance requirements per Medicare that need to be in place to receive that payment for medical direction. Again, I bring all of this up to make sure you really understand the inner workings of all the different models, what the payment looks like, to be paid at a certain level, what those compliance requirements are. Because inevitably, if you are talking with your group, if you are talking with a subsidy of some sort, these will come into play and you need to be educated going into those conversations. This next slide shows you the CRNA opt-out states. So again, any state in green is a full opt-out, meaning CRNAs can practice 100% independent. Red is no opt-out, and then blue there is a partial opt-out. Over here shows you states where you can have an anesthesia assistant working. Again, we see that as less prevalent, but it's out there and it is a viable practice model, which helps to drive down some cost as well. So after we've looked at what anesthesia costs are, what the care models are, we next have to understand the reimbursement. As I said early on in the presentation, anesthesia reimbursement has declined from 2019 to 2024. This slide further reiterates some common conversion factors for commercial versus other. So we're down here at 2024, the national ASC Medicare conversion factor was $20.43. Based on your locality in the country, that could either be higher or slightly lower. If we look at how does commercial insurance pay, national average commercial conversion factor is around $85. We'll see a range of 81 to 89. The median of that is 78. Now, we've worked in some markets where the average commercial conversion factor for anesthesia is in the $50, $60 range. So it's highly variable based on where you live across the country. What goes into the reimbursement methodology? It's not as straightforward as a surgery center where you have a CPT code, you might have a HCPCS code, and those get billed out. With here, you do have a code that's associated with the procedure being done. You may also have modifiers that get applied based on if they're doing post-op blocks, pre-op blocks. There's the conversion factor that comes into play, like we talked about, and that's what truly drives the reimbursement year to year. In addition, every procedure that's performed has an assigned base unit, which which should correlate to acuity. And then you have time units. So one time unit in anesthesia is every 15 minutes. So based on the length of the time the procedure is performed, it gets assigned time units based on that 15-minute increment. So anesthesia reimbursement is, I would argue, a little bit more complex than what we see in the ASC environment, and needing to make sure you understand what that reimbursement looks like and how it's calculated. This is an example of a procedure for an incisional hernia with a post-op pain block. So for that particular procedure in the anesthesia code, it's assigned 6 base units. This physician took 1.5 hours to perform the procedure. That's 6 time units. As I stated, they also did a post-op plain block, which allowed them 8 additional qualifying units to get to total units of 20. So if we take those 20 units and see how does that play out from a reimbursement, if we purely look at it from a national Medicare rate, we take 20 units times a conversion factor. That facility for that procedure will only receive $418 for a Medicare patient. If we look at the national average for commercial, if they're getting over $85, that procedure would then get paid at $1,700, and then a low commercial rate at $40, $800. This slide also illustrates to you the significance of your payer mix impact on anesthesia. Just like a high Medicare, Medicaid payer mix on your facility impacts you, it also impacts anesthesia. And as you can see, it can vary tremendously between Medicare and commercial. So, after you have fully digested everything you need to know about anesthesia, the next step is to talk about what is your strategy at your ASC to more efficiently, effectively partner with your anesthesia. We look at it in a multifaceted approach, and there's many areas that need to be looked at, which we'll cover today. One, room utilization. You need to evaluate your care model, as we've talked about. You need to ensure who's ever doing revenue cycle for your anesthesia providers are doing it effectively. So much like your ASC revenue cycle, anesthesia revenue cycle. Payer contracting, ensuring that they are optimizing their payer contracts, at least for commercial in the market, ensuring you have aligned incentives with anesthesia, and then ultimately deploying the strategy to more effectively partner. The number one step when we work with surgery centers and they're coming to us and saying, hey, we are having problems, not so much with staffing anesthesia, but they're coming to us and saying they're struggling financially, their revenue is not keeping up with their costs. The very first step we take with that facility is take a look at their facility utilization. Well, it's just as important for you as a facility to run efficiently, maximize your use of time. It's equally as important for anesthesia. So we highly recommend facilities complete a full space assessment, taking a look at how you're utilizing your facility. And then if you have gaps in the schedule, if you're staffing a full room every day but only running half, those are things that will substantially impact your anesthesia providers. They need to be running as many cases through those rooms just like you do to maximize their staffing costs. So take a look at your block time utilization. We have found facilities that inherently didn't run as efficiently as they could. When the anesthesia conversation started coming about having to subsidize anesthesia, it did push the facility to make some changes. So we see this as an opportunity. If you haven't been able to effectively maximize your space use prior to these anesthesia conversations, this could be an opportunity for you. In addition, we have some centers that creatively are scheduling, looking at reverse scheduling. What we mean by that is sometimes you'll have a physician have a block in the morning, you have a physician a block in the afternoon, and you have dead time in the middle of the day where you have staff. Some physician or facilities have said, hey, we're going to schedule backwards in a physician's block. So instead of starting Dr. Jones at 7 a.m., we're going to start him at that back of his block so he or she bumps up to the next physician and then work backwards. What that does, it allows your staff to come in later with no gap in the middle of the day. It also helps your anesthesia providers. You should consider running fewer days, fewer ORs, shorter days. So, this is the key first step to maximizing your space and helping anesthesia most efficiently utilize their team, which in turn, if they're asking you for some sort of payment or subsidy to help support it, it will help you deter those costs as well. The next step we also encourage facilities to look at is the care model in place. Once again, this needs to be driven by clinical physician folks, your doctors, anesthesia providers. Every market is different, but purely from a financial standpoint, we do encourage facilities to look at different care models. Here's an example. If you assume your facility runs an 8-hour day over 250 days per year, let's assume an anesthesiologist makes $500,000 a year, a CRNA at 250,000. And then let's say you have 3 rooms, 4 rooms, or 5 rooms. If you run an all MD model, here are high level costs to run 3 anesthesiologists, 4 anesthesiologists, and 5. This does not even account for an extra individual, maybe to provide breaks, lunches, perform regional blocks, which would be an additional cost. On the flip side, if you have a CRNA only model, this is the variance in cost, just again based on pure salary. So there's savings there. Medically directed model, if you recall, you can oversee or medically direct up to 4 CRNAs. So if you flip into the fifth room, you will need a second anesthesiologist. This becomes problematic for facilities. We see it all the time that are running 5 rooms. They have a medically directed model. Anesthesia is appropriately having struggles justifying that expense because it requires them to bring another physician on site once they bump into that fifth room. So anything you can do to get down to 4 rooms for them is going to help you as well. And then lastly, a medically supervised model. Anesthesia can supervise as many CRNAs as they need. So that's why that cost doesn't go up. Again, this is just to illustrate at a high level the different cost structure with the different care models that you might have running. The next step we always take a look at is at some of the ASCs we manage, we do the revenue cycle for anesthesia. So we have a control and line of sight to how well we're doing. In many cases, we're working and contracting with anesthesia providers where they are performing their own revenue cycle functions. If they are asking you for a payment or a subsidy, just like you wouldn't not check in on your own revenue cycle team, we encourage you to build something in your contracts with the anesthesia provider that allows you to validate their revenue cycle processes. You can build in different metrics they have to report. There's a variety of ways to get there, and SMP can help you with that if you're ever looking to renegotiate those agreements. But you need to be sure they're effectively collecting for what they're performing at your facility. And we have worked across the country. Some groups do it exceptionally well. We have seen in other cases they haven't. And so you need to make sure if you're paying a subsidy that they're maximizing the reimbursement, getting cases out the door, and collecting effectively. In addition, from a contracting standpoint, you need to make sure, as best as you cannot know and have knowledge of their payer contracts, but you need to have a good understanding of the market. Most often, we can back into the per unit costs as we're assessing the revenue cycle and cash collections. But again, that's a critical step. With that said, we have seen in some markets across the country, the payers, that there really is no room for negotiation. And so going into those markets, anesthesia essentially gets issued the same conversion factor as every other anesthesia group. But it's highly important that you understand that and what goes into it. In addition, if you're in a heavy Medicare, Medicaid market, anesthesia may have little opportunity to impact the bottom line because it's so heavy with Medicare, Medicaid, and that's a key driver and factor you need to consider. We also spend a lot of time talking about aligned incentives. I think in general, most anesthesia providers and ASCs do have aligned incentives. Patient care is a primary focus, providing high quality care, being as efficient as possible, taking care of the physician owners who use the facility. So I think generally we see incentives are aligned. I think when we start seeing things diverge, it's because of these very difficult conversations on payment, compensation, or sometimes in an ASC world, we're asking folks to standardize to make it a more repeatable process. So, what we'd like to do in many of our contracts is build in some incentive matrix that you could just put as a service level agreement, or you could build it in that, yes, you'll help subsidize the anesthesia providers, but they have to hit certain targets that in general we should all be able to get our arms around. So, as an example, you could implement standard protocols, ensuring they all have the same post op nausea and vomiting protocols, making sure the medical selection criteria is applied uniformly across the board, pain management, you name it. So, standardizing those protocols to ensure all the anesthesia providers are following the same. We also look at patient satisfaction, whether that's actual satisfaction scores. What's the same day cancellation rate? Do we have pain management issues with our patients in recovery? A key one for us is also looking at operational efficiencies, making sure we're all rowing the boat in the same direction for room utilization, turnover times, making sure we're getting started with our first cases out of the gate on time. And in the case of anesthesia, that might mean they need to be there to get the pre-op pain block in. And then a big one through all of this, and with just anything in general, is a communication. Ensuring there's open communication, we're meeting frequently, it's shared decision making, and how do we more appropriately and positively partner with the group. But we do like to build in incentives and metrics in contracts where we're able to help align those incentives. I think the takeaway from all of this is whether you have employed anesthesia providers or contracted anesthesia providers, all of the prior slides that I've talked about and the strategies and things you need to look at absolutely need to apply. We have to work in partnership with our anesthesia providers. We need them to do surgery at our surgery centers. So we need a positive working relationship, and we need to understand the challenges they're facing to ensure we can fairly come to the table with them to figure out how we can support their needs in an equitable manner. For those of you that may be looking to subsidize anesthesia or anesthesia is requesting some sort of subsidy, there's a lot of different ways you can approach that. SMP works with our current clients on our contracts, and not one contract is the same. You know, it's very dependent on the model of anesthesia care being delivered. It's dependent on the payer mix in their market. We have seen contracts come in having a daily guarantee that you'll be paying anesthesia just to provide the coverage. We have a budgeted amount. We've seen monthly paid to anesthesia, and then we reconcile that maybe quarterly, meaning revenues they brought in with their costs going out. If revenue exceeded costs, we would reconcile that. We have incentive bonuses that are built in with those metrics. There is not a one size fits all approach, but there are a lot of creative solutions that, one, help you manage your budget and keep control of those increasing costs at the same time allowing you to recruit and retain high quality anesthesia providers. Um, on this slide, what we have put together for you is you can use your mobile device right now to take a screenshot, and it'll link you to a blog that we've done on optimizing anesthesia services. We also have put together a working Excel tool. If you just don't know where to start, if you don't know where or how to build out an anesthesia model and assess the revenue and costs, we've given you a starting point that you can take and fill in the information. It will not get you all the way to the end of how you might need to analyze your anesthesia situation, but it gives you a starting point of data points and information you might need to be able to assess your anesthesia providers and your contract again and or employment situation. Our goal is to help all of you. We know this is an ongoing challenge in many ASCs across the country. And we have to figure out how to work together as an industry and in partnership with anesthesia to ensure that we can allow them to practice in our environments at the same time making sure it's financially viable for them. We are always here to help and support ASCs across the industry, and more than happy to answer any questions after you've had a chance to watch the webinar. My information is on here, so feel free to reach out at any time, and we're more than happy to work with you and figure out solutions for your anesthesia challenges. Thank you for your time today.